A holistic overview on systems thinking includes the assumptions and external environment that have a say in generating solutions to specific problems. World Health Organization proposes building blocks for strengthening health systems, including service delivery, workforce, information, medical products, and vaccines. Systems thinking, borrowed from the field of information technology and computer sciences, is a dynamic concept that interlinks inputs, outputs, and outcomes required to provide solutions at hands. Ladies and gentlemen, it is my absolute pleasure to introduce Dr. Rahul Shidhaye, sir, who will be enlightening us with his insights on the topic for the session. Dr. Rahul Shidhaye, sir, is a senior research scientist and associate professor of psychiatry at Pravara Institute of Medical Sciences, Pune. Sir has done his MBBS from Seth GS Medical College, Mumbai, and residency training in psychiatry from BJ Medical College, Ahmedabad, and PhD from Maastricht University in 2018. Sir has been bestowed with UN Mehta Gold Medal for standing first in MD Psychiatry examination conducted by Gujarat University, India. He was selected as a fellow of the Future Faculty Program by the Public Health Foundation of India and was awarded a scholarship to pursue Masters in Health Sciences from the John Hopkins School of Public Health. So let's give him a warm welcome.
The pre-lunch sessions are always very tricky. You're all looking forward to your lunch. And the topic also doesn't sound very exciting, systems thinking. But I would like to thank the previous presenter for starting with the gratitude-based mindfulness, because I think that essentially captures all that what I want to present as part of the systems thinking. So when we were doing this mindfulness exercise, and the one thing was that we had to kind of say this, that I'm grateful for the present moment, I'm grateful for people around me, I'm grateful for whatever is kind of happening. Basically, I'm grateful for the existence. Now, the idea behind this is I'm essentially captured by this particular sentence. I am what I am because what we all are. And once we understand this, this is essentially the basis of systems thinking at individual level. I'm sure most of you or some of you may be working in the field of systems, health systems strengthening or systems thinking. Maybe others are in other fields. So I'm trying to kind of give a bird's eye view of what I feel systems thinking is all about and how this could be used in next 30 or 35 minutes or so. I think we are running a bit late as per the schedule. So I'll start with my formal presentation. And thank you so much for that mindfulness thing, because it also helped me to relax. I mean, it's always good to have that kind of a, maybe next time onwards, I'll do my own small mindfulness exercise before I start with any of these presentations. So I'm a trained psychiatrist, I'm a clinician. And many of my friends who were with me in my undergraduate days or postgraduate days, they constantly, many a times they ask me, so Rahul, tell us what's happening, what's new in your, what are you doing? And I tell them that I'm working in this area of implementation science, I'm into systems thinking, health systems strengthening work, and they're all kind of perplexed. So they say, oh, that's fine. Where do you practice? Tell me, where is your clinic? And I always have to tell them that, oh, I'm sorry, I don't practice. I do kind of, occasionally I see patients, but I'm not a full-time practitioner. And everyone is quite perplexed at that you're not practicing, and they're worried as well. They're worried simply by the fact that if you're not practicing, how you support yourself? Who kind of pays for your, who brings food on the table? I have a very good wife, so that's not a problem. But they're all kind of concerned about me in terms of how you support yourself. Is this kind of a career to do something in systems thinking or health systems strengthening or implementation science or public mental health? So many of my clinician friends or even my relatives, they're not really convinced that I'm doing anything worthwhile. And this may be some of your experience as well. So what I thought would be a good idea for me to actually focus on things such as we should be able, as someone working in the field of public health or someone working in the field of health administration, uh, health management, we should be able to tell why we are doing why we are doing what we are doing, and then what we are doing. So that is kind of my focus. That's where I come from. So when Dr. Raghupati kind of sent me an invitation to come for this particular talk, I thought, am I really someone who's an expert in health systems strengthening? No, I'm not. I'm actually not trained in health systems or health systems thinking or health system strengthening. But then I recollected that I've done a whole lot of work which actually goes back and how I applied systems thinking. I was not aware that this is what systems thinking is, this is what health system strengthening is. But then whatever problems we faced and we tried to kind of tried to solve them, and we came, and then basically it turned out to be something which was in very close alignment with what systems thinking was all about. So that's the reason why I decided that I'll talk about my own work for some time. And in the initial part, I'll try to give a very high overview of what systems thinking is about in general, and then a couple of papers which may help some of you who are in the audience who are serious about systems thinking and systems strengthening. And you may refer to some of these papers because I think they are like sheet anchors. They help you to kind of really understand the jargon, understand the language which is being used in this particular field. This is what I'm going to do. I'm just going to focus on why systems thinking. Once you are convinced that this is necessary, systems thinking is not optional. And this is an interesting YouTube video as well. I mean, if some of you are interested, you can just search in YouTube why systems thinking is not optional. Yesterday I heard that video. Once you are convinced that systems thinking is essential, then what are some of those jargon or language or terminology related to that? And then finally, I'll talk about my own work, which is kind of aligned with systems thinking work. So as I said, most of my clinicians, even my parents used to ask me, there are so many health challenges. People are having depression, people are committing suicide, people are dying of infectious diseases, people are dying of very simple things. There are lots and lots of problems which are health related, which are related to, allied to health. Why don't you just act? Just act. Why research? I mean, whenever I say that I'm a researcher, I'm a full-time researcher, most of the even younger generation and many other people, like, they have a very weird look on their face that they say, I hate reading research papers. That's true. I mean, even I hate reading research papers, by the way, even those which I've authored. So that's not something which is weird. But what is weird is the fact that people think that this whole research and thinking and all that is kind of useless. We should act because it is necessary to act in first place. So some of you might have heard about this Operation Cat Drop. So Operation Cat Drop was an operation where cats were actually kind of airdropped by British Royal Air Force in Borneo. Now, why the cats were dropped? Because there was a very high population of rats, and there was plague and typhus epidemic in Borneo. And why the rats had increased? Because the cats who were actually eating the rats, they had died of, they were eating lizards, and those lizards had a very high levels of DDT in them. And eating lizards and also having contact with DDT, the cats in the local population were dying. Now, why DDT was spread? DDT was spread because there was an epidemic of malaria. And this was done by the World Health Organization in 1960s. So to summarize this in one single sentence, it is today's problems are yesterday's solutions. Yesterday we thought what were the solutions turn out to be today's problems. For example, hunger was a big problem, and then we ended up having we had green revolution, and we had massive food production, and today's problem is non-communicable diseases. And again, in no way I'm trying to say that that was wrong or this is wrong. It's just that because we prioritize doing whatever we feel is the best thing to do at that point of time, we may end up creating more problems. And there are lots of unintended consequences of what we do. And that's the reason why we have to not just do it, Nike. That's not just the way, but we also have to think. Thinking is a complex cognitive process where we try to understand information and knowledge around us to make sense of the world, to make decisions, and to solve problems. That's what essentially thinking is. That's how cognitive psychologists define thinking. So the first thing which I wanted to kind of underline, and again, no one actually taught me in this public health entire sort of whatever I learned, no one actually told me that you are here in the business of thinking. There's also, this is a serious business of thinking followed by research. We were all constantly reading papers, not really understanding how this is all connected. So thinking is important as much as doing is important. Doing is equally important, but thinking what happens behind, what happens in the back end. So front end is we the speakers, but a lot of effort has happened in the back end. That's also equally important. Without that, nothing would have happened here. So front end is as important as back end is as important as front end. And this is where the relationship between thinking and doing comes into picture. Now there are two ways of kind of thinking. One is a very straightforward, very simple way of thinking is pick up a problem, break it into parts. So break problems into component parts and try to address one part at a time. And just kind of have a very logical and clear reasoning to try to address that particular component. Forget about other components. That's generally analytical thinking, breaking down and looking at the parts and components. As opposed to that, a systems thinker would try to actually look at not individual components, but how the components are interrelated, how they are related to each other, how they are dependent on each other, how they are connected, and how the interaction between each of them actually leads to different kind of phenomenon. Just to give you an example, most of you must have visited a zoo. Now in zoo, what happens is there is a sort of a space for each and every animal or a bird. So the behavior of that animal or a bird in a particular cage is one way of that. And when you kind of open the cage and everyone is out there in a jungle, then their behavior is completely different. And that's the reason why most of us don't visit jungles, because we are actually afraid of what will be the sum total of the behavior of all the organisms put in one place. So that's how what's the difference between an analytical thinking or a systems thinking and how they are different. I got this particular idea from a very nice book from Meadows. She had worked extensively in this particular area. The reference is on the next slide, or the reference is on the same slide. Thinking in systems. And she explains this very beautifully, that why systems thinking is necessary. And in the introduction, right in the introduction, she says that I'm not trying to say that analytical thinking is not important. It is equally important. It is equally important to break down complex things into components and try to understand them. But at the same time, we also need to understand that how they interrelate, how they are connected, and what is the sum total, which is the total is more than the sum of the parts. We need to understand that. So as much as we need systems thinking, we need analytical thinking. So how we kind of then understand these interrelationships and interconnectedness and dependencies. And for that, what we need is models, or what we need is theories. And one famous statistician, George E.P. Box, and there are box plots and things like that, what he said was all models are wrong, but some of them are useful. And because some of them are useful, we need to kind of use models. We need to have some kind of a representation of a complex object, phenomenon, or a system into something which we understand. And that's where the role of models and theories come in. And again, as part of our curriculum, we generally don't, we are not really trying to link theories and models with which we actually do on ground. And I thought it is important to kind of, in implementation science, in health system strengthening, there are now kind of people who are trying to kind of provide this synthetic kind of a knowledge where they are trying to distinguish between theories, methods, and tools. Otherwise, it becomes very, very confusing. So in the kind of work which I'm associated with, we now have papers, and this is David Peters' 2014 publication, and this is kind of an editorial for a series where they have used multiple theories and models and tools to address a particular health system challenge. So you could actually refer to this particular series. I have not provided the reference over here, but you can always search for that. So he kind of describes multiple theories. So one is this general systems theory, which was proposed by a biologist, Ludwig von Butterfly. And this is this is not a specific domain, specific theory, but it applies to biology, technology, psychology, and multiple other fields. And all that it tries to do is it tries to help to understand how things are interconnected, what are the feedback loops, and so on and so forth. So someone who is serious about systems thinking need to understand some of these theories. The second is a learning organization theory. So what I was referring to, today's problems are yesterday's solutions. This is one of the things which was explained by Peter Senge in his book, The Fifth Discipline. And he has also come up with this learning organization concept. So the learning organization is an organization which tries to solve problems and improve its performance based on a shared vision amongst its stakeholders or employees. They're encouraged to come up with mental models, they're encouraged to come up with their experiences and address things which they think are kind of important. Then there is cybernetics, which is also proposed by a psychiatrist and a fellow anthropologist. So this also talks about connectedness and control of different feedback loops. The idea is not to go into the details of these theories, but the idea is to kind of understand them in first place. Again, why I'm stressing this point is because as students of public health, we were never told that you should have this bigger picture. You should understand theories first and then kind of apply them or have that kind of a connection. Now, here I am reminded of a workshop which Dr. Raghupati and I had attended when we had this agent-based modeling, and we had no clue where this whole agent-based modeling comes from. So agent-based modeling is kind of a method where you have a simulation. It's a computer simulation where you have an individual, and then you simulate what will happen to that individual if that individual interacts with people around that person, and then environmental factors, and you put the rules for that particular interaction and then run a simulation and see what will be the scenario. So most of these COVID predictions that what will happen, how will the COVID spread and when it will end and all that were based on this agent-based modeling. Now, when we were sort of researchers, we were suddenly introduced this agent-based modeling and the jargon around it without really understanding that it is part of a bigger understanding of what systems thinking is. Then there's a network analysis, and again, it is really exploding in nature. So network analysis is the application of network theory to various sort of public health social organizations, individual organizations, societies, and they try to see the connections between different nodes. Who is most connected? Who is at the center of that network? Who is at the periphery? What happens to people at the periphery, and what are their strengths of associations, and so on and so forth. Then there are various tools such as causal loop diagrams and process maps and system archetypes. Now what happens is people develop most of these things and then they kind of push them as if like this is the only thing. Like people who have developed system archetypes, they try to see everything in the world from the systems archetypes point of view, or people who have developed process maps. For everything there's a process map. So, well, we have to kind of just take it with a pinch of salt or a bag full of salt and try to kind of see how they're useful to us. So I've just tried to put this slide for people who are seriously interested in application of systems thinking in public health. To David Peters, and he has written a very short, simple editorial. There's a nice table where he explains theories, models, and tools. And some of you who are interested in implementation science, there's a very similar paper where the author, Per Nilsson, tries to make sense of various frameworks and models. And so what's the difference between a theory and a model and a framework and a theory, and how many theories are there? In implementation science, again, which is actually not a very old field, there are some close to 150 theories, very closely linked. But then what happens is it confuses the people. It confuses people like us who are consumers of those theories. And this is where we have to cut the clutter and understand the jargon. This is a very sort of a recent publication, just published a couple of months ago in January. Thalen and her group, in January, they published this particular thing on systems thinking for health action framework. So what they have done is they have done a systematized literature review, looked at all the papers, and also did some key interviews, key informant interviews, and came up with the characteristics of systems thinking. So for for us, for people like us who are kind of new to this is kind of a distilled knowledge. And they try to sort of put forth the characteristics of what a systems thinker or what a framework which uses systems thinking should look like. And again, it is a repetition of most of the things, but it's a good way of synthesizing what is available. And the first point is that the one needs to understand so there are components of a system, there are different structures of a system, and one needs to understand the interconnectedness between them. One also needs to understand how increasing or decreasing something leads to increase or decrease in something else, as we talked about this Operation Cat Drop, where DDT led to decrease in something, which led to increase in something, which led to decrease in something. So these are the feedback loops, feed forward and feedback loops. One needs to understand them. One also needs to understand the leverage points. So leverage points are the points where there are certain areas in that system where if you kind of put in your efforts, the effect or the impact is quite maximum. So one needs to understand where those weak links or the leverage points are. And then also try to understand that systems are not static. It's not that once you had a COVID pandemic, then these are the set of people who had COVID and now no one will have COVID. People will keep coming, people will keep recovering, will keep dying. So there is kind of constant inflow and outflow, which is also captured in something called a systems dynamic modeling and stock and flow sort of diagrams which they use. So this is good to understand that there's a whole dynamism in this. And then they suggest using models, mental models. So use of mental models or theory is underlined multiple number of times in multiple publications, and use of simulations, agent-based modeling and things like that. So this is something which is pretty recent, and I thought it will be helpful for some of us. So now I'm going to talk about my own work, because I'm the best person to talk about my work or criticize it. And I'll try to link it with how we kind of made use of some of those systems thinking. So way back in 2013-14, we had an opportunity to be associated with multiple global mental health projects. And we were guided by two things which were happening at that time. One was this on the left-hand side, and it was a nice introduction before I started speaking about the systems thinking for health systems strengthening. This publication on the left-hand side, you see these are the building blocks which the WHO had proposed. D. Savni and Taggart Adam, a very nice publication where it tries to kind of provide a very comprehensive view of how systems thinking could be used to address public health problems. And they had the kind of proposed this building people at the center and 6 building blocks, which include human resources in terms of mental health financing, mental health resources, service provision processes, mental health information systems, evaluation frameworks, technologies, and so on and so forth. So this was some kind of a starting point, and there was a very nice sentence in the introduction of this particular thing, where it said that even the best of the interventions will fail if the system around it is not conducive for the implementation or scale up of those sort of interventions. So that and that is nicely also picked up in one of a very controversial movies. I won't go into the controversies of that, but there was a dialogue in this movie which was released last year which says, "Sarkar unki ho, but system to hamari hai." So that kind of underlines that whatever a new intervention one would take into the field, unless the system is conducive to that particular intervention, the intervention is going to fail. And at least in the field of public health, what's happening is we are failing terribly. And you saw that in COVID. I mean, it's a general statement, generalizations are not so good. But many public health interventions which are proven effective at the stage of randomized controlled trials, at the stage where analytical thinking is working, where you are breaking down things into components, where you are trying to see whether A works on B, it works. But when you take it in, so when you take that animal from a zoo into a jungle, then suddenly the animal is sadly eaten up. So most of the interventions which we prove in randomized controlled trials, that these are effective, these help. When they actually go out into the real world setting, they die. I mean, the mortality of the interventions in the early stages is extremely high. And people working in the field of public health are trying to address this problem. So one of the approaches is using systems thinking. And another was a disease control priorities network, which was happening around the same time. This was a third kind of edition of that. And they had also taken up this whole policies, platforms approach to scale up intervention. So these were our guiding principles. One program which we were involved in, this was funded by UK Aid, and this was a 5-country program spread over 6 to 8 years. And our idea was to integrate mental health. I'm a psychiatrist by training, so our field was basically to integrate mental health in primary care. Now, primary care had its own issues, but we wanted to kind of integrate mental health in primary care because that's exactly what the World Health Organization also envisions, that we have to provide treatment for mental health disorders, at least the first level of treatment in primary care. So that was our aim. Our aim was to kind of develop a mental health care plan, implement it, and evaluate it in a public health care setting. So when we actually started the work in the state of Madhya Pradesh around 12 years ago, what we found was we did a situation analysis. Again, when we did the situation, so interestingly what happened was, as part of that program, most of us were clinicians and rest of us were trialists, so intervention development trials. So very few of us were actually system thinkers. So either we were thinking in terms of how we deliver that particular psychological therapy or how we train doctors to deliver antidepressant medications, prescribe antidepressants. Beyond that, we were not actually thinking at the systems level. But one good part was that we started our situation analysis, or we started to look at things from a systems point, and we realized that the services were available only in the district hospital, not in other primary healthcare centers or the community health centers. It was only specialists. It was not a team approach. Nurses or no other care providers were involved. There was only pharmacology was there. In psychiatry or in mental health, it's psychological interventions plus drugs. But here it was only pharmacology, and that too only for severe mental disorders. So depression, anxiety, which is actually very common, that was not addressed. There was actually no drug supply. Drug supply was extremely irregular, or generally the psychiatrists used to say that take drugs from outside. There was nothing like mental health information system. So what was happening, no one knew. How many people were treated, how many actually got better, nothing of that sort. There was the district health leadership exists, but they were not even concerned with mental health. And this model for mental health could be used for other neglected or non-communicable diseases as well. And that's the reason why I'm sharing this. There was, interestingly, what happens is in public health, we tend to kind of say that government is not allocating funds. My experience is that whatever funds are allocated by the government, people are not able to utilize them. At least in the mental health sector, the utilization of funds is 50%. And 50% are sent back to the finance ministry. The next time they give less. And there is no capacity to utilize funds. And that's one of the major issues. So then we kind of did our work the way we did for a couple of years, 2-3 years. And at the end of around 4-5 years, what we were able to do was, we were understanding that whole system, and which I'll present on the next slide. We were able to kind of make an inroad and establish ourselves into the public health system, so that we now had a mental health clinic. We called it Mankaksh. This was the name which was suggested by local stakeholders. So we had Mankaksh in all rural hospitals, which are sub-district hospitals. We also had a component of psychological interventions, not delivered by the research team, but by the existing state health system, who appointed a psychologist, and through him, they actually started delivering psychological care. We ensured that there was a regular supply. We understood how the drug supply chain works, and then how to integrate our drugs, because WHO has essential drugs list. So our job was to kind of integrate those essential drug lists into the existing system of drug procurements. We also understood their existing information systems and added a couple of indicators from our end. So you are anyway picking up information on these 7 indicators. Why not add those 2 indicators which are for mental health? And we were also able to kind of shift this leadership to a district health officer. Of course, this led to increased utilization of funds. This is all captured in one of my papers. Now, the proof of the pudding is in eating or something, whatever that goes. So whatever we did, that was a couple of years ago. We are not part of it now. But now in the state of Madhya Pradesh, which is Actually, by geography, it's the second largest state in India. And in terms of area, it is bigger than UK. In terms of population, it is bigger than UK. Now we have a model of mental health care delivery in Madhya Pradesh. You can see on their website, there are YouTube videos which they have prepared. And they actually took our model without giving credit to us, which is perfectly fine. So they took this Mankaksh model, and now they have established Mankaksh in all the district hospitals in Madhya Pradesh. So there are 51, 52 districts in Madhya Pradesh. Each district has a Mankaksh, district hospital. We have still not gone to the primary healthcare level, but each hospital has a Mankaksh. That Mankaksh has a psychiatrist. Maybe not all districts, but most of the districts has a psychiatrist. There are trained medical officers who do a first level screening and treatment of depression. Nurses and other allied clinical workers are associated with delivery of services. There is a regular supply of drugs. There is a regular information system. This is not yet fully done, but the thing is, at least we have, where there was nothing. I mean, in 2011, 2012, when district mental health funds were sent, 50% of them back. Now, in our absence, and that's the best part of it, in our absence, I'm not associated with that program, none of my team members is, but the state of Madhya Pradesh, they consider Mankaksh as their flagship program, and they regularly monitor it, and they have their own system of tracking progress on all those parameters. So this was one model, and we could, so this is a YouTube link for that particular video, which is there on the website, on the YouTube channel. So what we thought that we took this whole systems approach, and we sort of, so at the very basic level, what happens is there's an interaction between a service provider, a clinician, and the patient. And that interaction has to be mapped very well. So we had very clear process maps, very detailed process maps of how that thing happens. Now, for that to happen, we had to provide training, but along with the training, constant implementation support had to be provided, and this was based on our own continuous quality improvement methodology. And for all that to happen, there had to be a health information systems in place, regular drug supply process in place, and involvement of the leadership at the state level and the district level. So these are some of the things which so this is the systems building blocks. This is the implementation support which I was referring to. These are the process maps, and this is the continuous quality improvement process. Again, all these are in detail here, and these are the summary of our learnings. I did say all that. So this is how we use systems thinking to integrate something which was non-existent in a state which had no particular intention or interest to integrate mental health, but now mental health being part of that particular state. Now I come to another program which I was sort of fortunate enough to co-lead simultaneously, and this was a program which was, so earlier that PRIME program, the program for improving mental health, was in alignment with the health system, the public health system. Now this program we tried to undertake using, working without any assistance from the government in the eastern part of Maharashtra, Vidarbha region, and where we worked with community-based organizations. So we worked with community-based organizations. As a technical organization, I was associated with Sangat and Public Health Foundation of India. So Sangat worked as a technical implementation partner, and it worked with organizations which had no background in mental health field, but but they had a strong community connect. So we trained their existing staff to provide psychological interventions, screen people, follow them up, and so on and so forth. And what we found was that there was, at the community level, in a particular area of 100,000 population where we were working, we were able to significantly increase the contact coverage. We were able to establish that access to care, which is picked up as part of the contact coverage, was equitable. We were also able to establish that care was sought from general physicians. So what started happening was they started to realize that depression and anxiety are real health problems, and for that, help could be sought. But for them, general practitioner was the person from whom to seek care. So the pattern was that they usually sought care from general physicians, and there was significant improvement in mental health literacy. Again, this is summarized in this particular toolkit. I was not aware that toolkit is a very controversial word. 6 years ago, toolkit was a normal word. So we have a Vishram toolkit if some of you would like to kind of uh, read about our experience or how we did it. And what we did was basically worked with community-based organizations, tried to change the discourse about mental health, that it is not just about severe mental disorders, it's not just about psychosis or epilepsy, but it's also about depression and anxiety and other multiple wake complaints, which can be addressed as part of the mental health programs. And we had kind of these gram panchayats having resolutions passed that they need services from district mental health program, especially for severe mental disorders and so on and so forth. Unfortunately, what happened with this was the program supported by Tata Trust. As soon as the program ended, because we did not have any government kind of linkage, with us, the program also ended, unfortunately, and now there is hardly anything on ground. And this was, we were able to kind of understand that which systems one needs to align to scale up, which systems would lead to different kind of outcomes. So these are the two sort of examples. And simultaneously, we also had another consortium where we looked at mental health systems in low and middle income countries from, again, a very high level overview. And we tried to summarize our learnings from two other programs in this particular project. So in nutshell, how we applied systems thinking was at the community level. We had a program where we worked with lay workers, lay health workers, and provided services. Prime was another program where we worked with existing health system, and now it is scaled up. And all this is kind of integrated as part of the learnings were integrated as part of the health systems work in Emerald program, which was more about what are the inputs, processes, and outputs for mental health system strengthening. Now, I have focused more on mental health system strengthening because that's my area of work. But I feel that some of the learnings from our work could be applied to areas which are neglected, or could be applied to areas where very little has been done, especially in low resource settings. So some of those learnings pretty much can be used. This is my last slide. And to end, what I felt was it's important to kind of start to summarize systems thinking. And I don't know how many of you, so Vasudhaiva Kutumbakam is something which we always read, and not just here in the logo of Symbiosis, but we generally also, it's kind of a very commonly used word, term. But I think very few of you must have actually bothered to look at the entire shloka from the Upanishad, which basically says that Ayam Nijam Parovetti Gananam Laghuchetasam Udaracharita Namastu Vasudhaiva Kutumbakam. So those who have Laghu Chetas, whose Chetana, whose thinking is Laghu, small, they see that this is mine, this is not mine. This is me, this is not me. While those who have a broader vision, they see everything is one. They see that this is all Vasudhaiva Kutumbakam. So I think this very succinctly summarizes what systems thinking is all about. We do need analytical thinking. We do need to break down complex problems into systems, but we also need some people who can see things from a higher level, who can theorize about it, who can have models, who can simulate those models, who can actually implement those models on ground, generate data, based on the data, revise those models, and this is work in progress. So as a researcher, one thing I've always realized is that this is huge. And of course, I'm thankful to whatever is happening because, as I said, Ubuntu philosophy, I am what I am because of what we all are. But science progresses in baby steps. There's nothing like, there is just one Nobel Prize here and there, but there are so many scientists who are toiling around, making these systems, making these small, small steps and trying to advance field in their own way. I hope I gave you at least some inkling about what a systems thinking could be like using my own examples, and I would be happy to take questions. Also, I have not put my email ID there, but Rahul Shidhaye, it's rahulshidhaye@gmail.com. I'm happy to kind of connect with any one of you. Thank you so much for patient listening, especially in a pre-lunch session. Thank you.
That was indeed an interesting session. Thank you, sir, as your passion for this topic really came through in your speech, and it certainly gave us a lot to think about systems thinking, the theories, and the applications regarding it. Now, may I request Dr. Samita Jadhav, Director of Symbiosis Institute of Health Sciences, to felicitate Dr. Rahul Shidhaye, sir.